Good afternoon. Welcome back after tea. As promised, afternoon sessions after tea is the best. So we shall have the best for the last sessions. So next, I would like to introduce to you our next speaker, Professor Teo Eng Kiong from the Department of Gastroenterology, Changi General Hospital. He will give us an update on chronic hepatitis B infection, clinical manifestations, and their serologic diagnosis, management upon diagnosis and things to look out during regular surveillance, and treatment indications and options. I think I've read out all the programs for this afternoon, right? Now let's have Professor Teo to give us his first delivery of the lecture.
Okay, I think there's still some sunlight, so we'll try to complete the program early and we can still go for some outdoor activities. So, chronic hepatitis B, what to do after diagnosis? Like what Wan Cheng shared earlier, when a person is told that he has hepatitis B, they literally go through the 4 stages of grieving. And then the last stage after acceptance, that's where we see them. So, I think we are actually the more fortunate lot, because by then when they come to us, they say, okay, what should I do? And how can I go on from there? And they have gone through this stage of denial. No, I don't have hepatitis B. I get angry, who passed it to me, that kind of thing. So when it comes to us, it is usually, it's important to set what are the expectations, because it is important to follow up these patients, to look for a few things. And I'll go through that, in my talk. They can come to you about between 2 to 4 times a year. And a lot of times it seems very routine. And if it's not well stated right at the start of the follow-up, the patients may think that it is a waste of money, he's being tricked into coming to your clinic regularly, that kind of thing. And after that, he disappears. And more often than not, these are the ones that show up in your clinic a couple of years later in a very bad shape. And, things will be too late by then. So that's the background for my talk. Before we go on, let's have some definition. What's the definition of chronic hepatitis B? What are the risks that chronic hepatitis B patients face? Why do we want to monitor them? How to monitor? How frequently do we monitor? And then a summary. So chronic hepatitis B refers to patients who have HBs antigen more than 6 months. I think that's been said quite a few times today. And that's something which we should remember. So we should not do one blood test, HBs antigen positive, and say, look, you have chronic hepatitis B and you need to go on this, for your whole life kind of surveillance program. You need to do it another 6 months later, and if it's still positive, the patient has chronic hepatitis B infection. Active viral replication, we used to use the E antigen status. Now we tend to look at HBV DNA. For E positive, we look at more than 5 logs. For E negative, more than 4 logs. So if they have high DNA level, they are in a active replicative state. Now, if the patient has elevated ALT and there's no other cause for the liver inflammation, we say that the patient has immune clearance. That means the body is trying to, the body has a reaction against the virus and is trying to clear it. And if you do a biopsy, usually you see some significant inflammation on histology as well. Now, we talk about cirrhosis. When a patient develops cirrhosis, it can be diagnosed based on histology. That means you do a biopsy, you diagnose histology. Or the patient can actually present with signs and symptoms suggestive of portal hypertension, like ascites or varices. Sometimes you will see an ultrasound report that the patient has early cirrhosis, or CT scan report of patients having cirrhosis. Usually this is dependent on the surface, the nodularity on the surface, irregular surface on either the ultrasound or the CT scan, and it can be fairly accurate. So if they can pick it up, the chance of patient being cirrhotic is significant. But if they report a normal ultrasound or normal CT scan, the chance of patient being cirrhotic is not zero. Okay, so we are talking about sensitivity and specificity here. Now, the latest toy in the market is this thing called FibroScan. It is something which is quite simply done. You just aim a probe and it fires off an ultrasound wave, and depending on how fast the wave gets reflected, they did a calculation and come up with some figures to suggest the level of fibrosis of the liver. And usually it's a certain range of reading, and you can sort of classify the patient under F0, F1, F2, F3, or F4, F4 being cirrhosis. Accuracy-wise, fairly accurate, certainly not as accurate as biopsy, but it's a good tool because the patient do not have the risk of a complication of biopsy. Now, we talk about decompensation. When a patient goes into decompensation, basically it means that the liver function is deteriorated to such an extent that it starts to show up in the patient. And you'll see it as a reduction in albumin, elevation of bilirubin, elevation of ProTime or IMR, and if you do a CTP score, it will be more than 6. So that's the definition. When we talk about cirrhosis, we talk about decompensation, we talk about chronic hepatitis B. Now, what kind of risk does patient with chronic hepatitis B face? I think the top of mind is always this thing about liver cancer. Liver cancer is something, if you look at maybe just even a decade ago, or slightly more than a decade ago, when a patient is diagnosed with liver cancer, it is almost like a death sentence. Like the patient lives for another 6 months to a year, and then after that, you probably see his obituary in a newspaper. So there's a lot of fear about liver cancer, and there's also a lot of data on the risk of liver cancer in patients with chronic hepatitis B. Now, the next one is they develop the risk of liver cirrhosis, and cirrhosis itself is a risk for liver cancer development. And of course, cirrhosis, the patient can develop a liver failure, can develop portal hypertension, for which the patient can present with ascites or bleeding varices. Patients with liver cirrhosis are at risk of getting infection, and when they get infection, it is difficult to clear as well. That's because the liver is the main immune organ in our body. And there are other immune complex diseases like polyarthritis nodosa, some kind of skin rash, and those are more immune complex diseases due to the hepatitis B antigenemia. Now, what's the likelihood of a patient developing HCC in chronic hepatitis B patient? Well, it's been quoted between 50 to 200 times. And you have to remember this, that patients with chronic hepatitis B can actually develop hepatocellular carcinoma without being cirrhotic. That is quite unlike many other liver disease. For chronic hepatitis C, for chronic alcoholic liver disease, for any other chronic liver disease, they develop chronic liver cancer when they has established liver cirrhosis. But for chronic hepatitis B, because the virus is carcinogenic by itself, the patient can develop liver cancer even though they are not cirrhotic, and we have to watch out for that. It's also known that the higher the DNA level, the risk of developing HCC increase. And therefore, if you look at it, if they are persistently in a replicative state, those are the ones which you know that they are at higher risk of developing HCC. But there are other factors which includes the genotype of the virus, whether is it C or D, age of the patient. Of course, as the patient goes older, when the duration of infection is longer, there's higher risk of developing HCC. Alcohol consumption is something which is a no-no for chronic hepatitis B patient. You add alcohol to chronic hepatitis B, they really get into big time trouble. Okay, and we know that when you treat patients who actually satisfy treatment criteria, this is not patients who do not satisfy treatment criteria. We are referring to patients who satisfy treatment criteria. You treat them, you bring their DNA level down. It's been shown to reduce HCC risk, and this is a very interesting paper that was published in 2004 by the Taiwanese group, Professor Liao.